Guys, I hope you're doing fine. Today we are doing rheumatology, okay? And rheumatology again, it is a medicine structure, okay? So before we go with rheumatology, before we start the branch, I will just give you a few points. So at any rheumatology case, at any case where the patient is coming with joint pain, we know how to explore the presenting complaint, Socrates. But make sure if the patient is coming with joint pain, you have some principles. Number one, which joint? Doctor, the left. What about the other joint? Are you able to do your daily activity? Doctor, knee pain. Which knee? What about the other knee? Are you able to walk? So any pair, compare. So whenever you're having a patient who's coming with pain in his joint or joint problem, always ask about the other joint and compare. So which joint? What about the other joint? Okay, so any pair, compare. Number one. And the effect, the impact of this problem on his daily activity. What do you do for a living? How is it impacting your job? So what do you do for a living? How is it impacting on your job? How is it affecting your daily activity? Are you able to do your daily activity? So the impact of the joint problem on his life and on his job if he's working. That's one principle. Okay, do not forget to bring number one, any pair, compare. Number two, the impact of the joint problem on the daily activity and on the job. Okay, now again, rheumatology, I will follow the medicine structure, which is P1, P2, P3, maftosa, same as any other structure. P1, P2, P3, maftosa. So P1, the patient is coming with joint pain. For example, shoulder pain. Shoulder pain, this is my P1, for example. So what to do? I'm really sorry about that. That sounds quite distressing. Can you tell me more about it? Explore the presenting complaint. He will tell you everything. Anything else? He will tell you another pain, another symptoms, fever. Tell me more about it. Anything else? And after that, so after exploring, tell me more, open question, and anything else, again, explore. After that, I will go to differential, DDs. And the DDs of the rheumatology are easy, simple. I will put them in a word called gross. G-R-G-H-R-R-O-S, gross. These are the differentials for any joint problem. What is gross? G for gout, H for hemarthrosis, R for rheumatoid arthritis, R for reactive arthritis, O for osteoarthritis and osteoporosis, S for septic arthritis, and S for sport injury, fall. So that's gross. So gross is what we use for differential of joint pain, G-H-R-R-O-S. After that, P2, past history of presenting complaint. Have you had this before? Past medical condition. After that, P3, which is DESA. And be careful because DESA is not going to be there in all cases. Take what is relevant. For example, rheumatoid arthritis, smoking is very important. Gout, diet is very important. Sports injury, trauma, exercise, very important. Maftosa. So I will give you, this is the general structure. P1, tell me more. Anything else, tell me more. DDs, gross. Then don't forget that in maftosa, O and the S, occupation and social, will come early after the presenting complaint if the problem is chronic. What do you mean? If the problem has been there for 2-3 months, don't forget to bring occupation and social forward. So what do you do for living? How is it affecting your job? How is your mood? Ask about the mood as well, okay? And how are you managing on your daily activity? So always bring psychosocial early after the presenting complaint. Think about it. If a patient is having hip problem, can't walk, problem in the hand, joint, shoulder, can't do daily activity, so be careful. Ask about the impact, the psychosocial impact of the condition on his life, okay? So when we come to investigations, okay, you must, don't forget, blood, and don't forget X-ray on the joint. So blood and X-ray on the joint. Blood, I will do full blood count. I will do rheumatoid factor. I will do infection marker. So don't forget blood and X-ray on the joint. Don't forget these two. And in treatment, I will involve, number one, I will give painkiller. Number two, I will involve rheumatologist, occupational physiotherapist. So painkiller, rheumatologist, occupational physiotherapist. So painkiller, rheumatologist, occupational physiotherapist. Don't forget it will be involved in management. So I'd like to give you one last piece of advice, that with any joint pain, two things you must not forget: trauma and fever. Why? Fever to exclude septic. Fever to exclude septic. And in safety netting, again, fever. So fever at the start of the station to exclude septic, and fever at the end of the station as a safety netting for septic. So start your station with fever and end it with fever, okay? So now let's start the first station, and I'm going to use my structure on each and every station, and we're not gonna go far from the structure, okay? So the first station is your RNF reactive arthritis. The first station is reactive arthritis, okay? So your RNF to doctor, 29 years old, John, came to the hospital, pain in his knee. So reactive arthritis. Presenting complaint, pain in the knee. Can you tell me more? And always say, I'm really sorry about that. Are you comfortable talking to me? Sympathy and empathy. Can you tell me more? He will tell you about the knee. Always ask which knee, what about the other knee? Are you able to walk? With the pain in the knee, he will tell you, doctor, swollen, painful knee. So any pain anywhere else in other joint? No, doctor. Anything else? He will say pain in the eye. Explore. Anything else? He will give you pain while passing urine or diarrhea. So the presenting complaints will be pain in the knee. Always explore Socrates. Always say which knee, what about the other knee? Are you able to walk? Always say apart from the knee anywhere else. He will give you another symptom, pain on his eye. Explore, tell me more. He will give you pain while passing urine and or diarrhea. This is the presenting complaint. Okay, so whenever he gives you pain in the eye, explore pain in the eye as if it's pain in the knee, exactly. Since on how did it start, okay? Then when you go for differentials, it will be he can't see, he can't pee, he can't bend the knee. Okay, what is the risk factor? In this case, reactive arthritis, sexual history. So always ask sexual history and IV drug abuse. Always ask sexual history and IV drug abuse, which is DASA, plus or minus. Sexual and IV drug abuse, go to day one. So always ask here sexual history. Why, Dr. Mo? We tell you that we are not here to diagnose only. We are here to diagnose and find out about the cause. So diagnosis, reactive, which we call it writers sometimes. The cause is STI. So for example, is the risk factor. So always ask about sexual history. And after that, I will take 2-3 differentials from all of this. The first differential should be fever all the time. Always ask about fever. The second differential is trauma. So fever and trauma must be excluded in every case. Always ask about sexual history, pain while passing urine. Always take sexual history here, okay? Okay. Travel history is a must because of contact. So travel history is a must. And when he gives you travel history, always ask what was happening there. Have you been sick there? Were you sick over there? Any health conditions over there? Okay? So, verbalize examination. Then come to provisional diagnosis. Reactive arthritis is a two things you must tell. Temporary, will go on its own. The symptoms are temporary. And it's autoimmune. So temporary and autoimmune condition, the body defense mechanism attack its own cells and instead of attacking the organism. Okay? Most people will get full recovery within a year. Okay, what is the treatment? I have 3 things here. I have joint pain, I have eye pain, I have pain while passing urine or discharge from the penis. So 3 things. Okay, so eye problem, knee problem, pain while passing or discharge. So investigations will be simply ESRC reactive protein, full blood count. Okay, investigation, rheumatoid factors as blood, urine, yes, urine dipstick, and urine culture, yes. X-ray on the joint, yes, definitely. X-ray on the joint, yes, yes. Then when I come to management, I will manage number 1, the knee, number 2, the eye, number 3, the STI. So for the STI, and for the knee and for the eye. For the eye, this patient will need steroid drops. For the eye, you will need steroid drops for the eye. This patient will need painkiller. And be careful, because we will give this patient the antibiotic. Not only, it's not to treat the reactive arthritis, no, it is to treat the cause. Because the reactive arthritis is a response. So we are treating the cause, which is STI, which can be bacterial infection, so the STI. So the STI, antibiotic, steroid for the eye, and for the knee, I will give NSAID, non-steroidal anti-inflammatory drugs. If it's not working, we'll give steroid tablets. If it's not working, we'll inject steroid into the joint. And if it's not working, disease-modified anti-rheumatoid drugs, which we call it the MARDs, okay? All this on one side, but don't forget that you are managing eye, steroid drops, STI, antibiotics, and refer to GOM clinic, and even STI screening, and the knee pain, which is reactive arthritis, which is reaction, okay? I will give them NSAID, non-steroidal anti-inflammatory drugs. If it's not working, steroid tablet. If it's not working, steroid injection. Don't forget the self-care, which is plenty of rest. Do exercise, slowly, ice pack, and make sure you build up the exercise, okay? And in this case, I will need a specialist, yes. I will need physiotherapist referral, and I will need occupational referral. But be careful, because when we talked about the MARDs, when we talked about disease-modified anti-rheumatoid drugs, that will be done. And when we talked about injection steroid, that will be done by rheumatologist. So we need 3 referrals: rheumatologist for further management, we need occupational therapist, and we need physiotherapist, okay? Occupational therapist on how to deal with the work, how to deal with jobs if you are working, they give you strategies, okay? The second case is rheumatoid arthritis. Rheumatoid arthritis, again, how can I help you? Doctor, I have pain in the joint. I'm really sorry about that. That sounds quite distressing. Can you tell me more? Which joint? He will give you small joint, hand and feet. So rheumatoid arthritis, don't forget, small joints, hand and feet, specific. Number 1, in the presenting complaint will be affecting the small joints, hand and feet. Number 2, morning stiffness. The patient will tell you, doctor, stiff in the morning, and with work, with movement, with using my hands, it gets better. So stiffness. So number 1, small joints, hand and feet. Number 2, morning stiffness, which means it is stiff in the morning, relieved by the end of the day. Okay. Number 3, he will tell you my joints are swollen, stiff, painful. So these are all specific for rheumatoid arthritis. Don't forget that in rheumatoid arthritis there is always risk factor, because we not only need to diagnose, but also we need to find out the cause. The cause for rheumatoid is smoking. So smoking is a risk factor for rheumatoid arthritis. Always ask about it in DESA, smoking, okay? And don't forget the occupation. How is it affecting your life? She will say, I'm a typist, I use the computer, and that's when basically I found out about it, okay? So basically, don't forget, after asking the questions for rheumatoid, which we said to you, 3-4 differential, but all the time we said start with fever and end with fever. Start with fever and end with fever. Start with fever and end with fever, okay? So that's it. So come to examination, verbalize examination, okay? Always ask about family history as well. Family history is important in rheumatoid, okay? So smoking and family history. So come to examination, verbalize that, I will examine the joint. Okay, again, provisional diagnosis. Provisional diagnosis, it's autoimmune condition. It is autoimmune condition. Again, the body defense mechanism attack its own cells rather than attacking any organism, and it runs in the family. Smoking is a risk factor. Management, as I mentioned to you, management, because she's coming with pain. So, painkiller, that's one thing. You need to do investigations like what? Again, infection marker, could be infection, rheumatoid factor. So infection marker, rheumatoid factor, ASR, C-reactive protein, for blood count, okay? And you need CCP antibodies, that's all for rheumatoid. Anyway, don't forget that when you treat number 1 painkiller, number 2, I need 3 referrals. Referral to rheumatologist, referral to physiotherapist, referral to occupational therapist. Okay, and don't forget what else in the investigations, X-ray on the joint, X-ray on the joint, X-ray on the joint. Don't forget X-ray on the joint, don't forget X-ray on the joint. And with management, you will be giving a painkiller, NSAIDs, and don't forget whenever you give NSAIDs, you give PPI, proton pump inhibitor. Don't forget, whenever you give NSAIDs, you give proton pump inhibitor. So NSAIDs, if it's not working, steroids. If it's not working, injection, steroid in the joint. And don't forget to talk about disease-modified anti-rheumatoid drugs. Who's gonna give the disease-modified anti-rheumatoid drugs? Who's gonna give the injection steroid? Rheumatologist. That's why you need to refer to rheumatologist. You refer to physiotherapist. Why? He will give you strategies about how to deal with the pain. Physiotherapist will give you strategies about how to deal with the pain. And also, you will need occupational therapist referral who will give you strategies on how to deal with work and how to do your job with this pain. But don't forget the cause, the risk factor, lifestyle, smoking. Don't forget to talk about smoking. Don't forget to talk about smoking. Don't forget to talk about smoking, okay? Okay, then that's rheumatoid. Then we need gout. You are an FY2 doctor. Janice, 45 years old, she presented to you with a complaint, pain in the big toe. Again, how can I help you, doctor? Severe pain in the big toe. Sympathy, empathy, I'm sorry about that. For how long? Tell me more. Socrates, anything else about the pain in the big toe? Any pain anywhere else in the joint? Which toe, left or right? Okay, or any pain else in the joint? And then always ask about trauma and fever, as we always say. Trauma and fever. The first 2 questions in any joint pain. Then go through gross. Go through gross, the differential, then P2, P3 maftosa. Okay, now we need the risk factors. What are the risk factors in gout? In gout, make sure you ask about diet. Make sure you ask about smoking, and make sure you ask about alcohol. Alcohol, they drink too much beer. So alcohol, they drink too much beer. Okay, in diet, again, positive. Okay, uric acid, it's too much uric acid in the body. So diet and alcohol, all right? And also I'll ask about smoking and exercise because of trauma. But these are the risk factors. Maftosa, as it is. And if the pain has been there for a while, psychosocial, however, it's gonna be acute pain. Now, examination, verbalize, examining, observation, and examining the big toe. Investigations like anything, bloods, full blood count, infection marker, rheumatoid factor, ASR, C-reactive protein, vitamins is very important in joint pain. X-ray in the joint. Treatment, again, in gout, in the acute, you don't need referral. You give NSAID or colchicine. In the recurrent, then you refer to rheumatologist and you give allopurinol. In the recurrent attack, you give allopurinol. But be careful because there is gout and there is pseudo gout. For that, you need to do joint aspiration. So don't forget that I will do normal bloods, as we said. And I will do joint X-ray, as we said. But we will do aspiration. But it's not your job, it's rheumatology job. Rheumatologist might take sample from the joint aspiration, okay, in order to check the fluids in your joint, okay, which we call it joint aspiration in investigations. Okay, thin needle will go through your joint, will take sample. Treatment, as I told you, in the acute attack, NSAID, non-steroidal drugs, and colchicine. However, if it's recurrent and repeated, we'll give him allopurinol and they will be referred to rheumatologist. So rheumatologist is the one that the patient will go to in the repeated attack. Okay? All right. Don't forget things that you do, things that you don't. Okay, things that you do: rest, lift your limb up, okay, lots of water, plenty of water, okay. So things that you do not put pressure on the joint. And if it came back, I said to you, colchicine and referral, okay. And very, very, very important, talking about the lifestyle. DESA is the cause. So talk about beer, that he shouldn't be drinking too much beer. Talk about smoking if he's smoking. Talk about diet, that he needs to modify his diet. So things that he should do, things that he shouldn't do. So diet and beer and smoking, very important lifestyle, very important to advise the patient, okay? Polymyalgia rheumatica. You are an FY to Dr. Margaret Smith, 73 years old, came to the clinic with pain and aches on her shoulder. And sometimes they say shoulders and hip. Shoulders and hips, or shoulder only, okay? Be careful, because that's a case of polymyalgia rheumatica. Whenever you have polymyalgia rheumatica suspicion, always think of eye problem, always think of pain in chewing, always think of pain in combing. So GCA, giant cell arthritis, pain on chewing, pain on the eye, pain in combing. So whenever you have one, ask about the other. If you have a patient with shoulder and hip pain, always ask about GCA. And if you have a patient with GCA, always ask about shoulder and hip pain, because they both autoimmune and they both come together. So this case, how can I help you? Doctor, I have shoulder pain or pain in the hips. Always Socrates. Which shoulder? What about the other shoulder? Are you able to do your job? Which hip? What about the other hip? Are you able to do the activity? All the time. Apart from this, anything else? She'll give you another thing. Tell me more. Anything else? Tell me more. So all the time presenting complaint. So polymyalgia rheumatica. What will the patient have? Pain, stiffness in the shoulder muscles, pain, stiffness in the shoulder muscles and the shoulder joint and hips. Started a few days ago. Okay? So both sides, not one side, not unilateral, bilateral. Okay? And all the time, polymyalgia rheumatica. What other symptom can you ask about? The patient might have tiredness, the patient might have loss of weight, loss of appetite. Okay? And it comes all the time with GCA, giant cell arthritis. So ask about pain in chewing, pain on combing, and pain in the eye. So always ask about these symptoms. And you have the differential gross. So pick 2, 3 differential, but one of them is fever. So always fever and trauma. P2, P3, mastosa. Okay? Now, polymyalgia rheumatica is autoimmune condition. So when you examine, verbalize observation and verbalize joints. It is autoimmune condition. It's autoimmune condition. The body fights its own cells. And what we call it, it's referred pain. So polymyalgia rheumatica is referred pain. It is referred pain. What we call it, it's pain in the joint referred to the muscles. Okay. Management, senior, investigations. What are the investigations? What we know. All the bloods, full blood count, infection marker, ACR, reactive protein, rheumatoid factor. What we know. Okay. Don't forget X-ray in the joint and the ultrasound scan on the joint. Don't forget. Okay. X-ray and ultrasound scan on the joint. What is the treatment? Steroid. Prednisolone is the main treatment for polymyalgia rheumatica. Whenever you have prednisolone, whenever you give antibiotics, whenever you have prednisolone, whenever you give prednisolone or steroid, talk about it. Side effects. Prednisolone or steroid will be given for 2 years. 2 years. Although the symptoms will improve in few days, this patient will be on steroid for 2 years. 2 years steroid. So discuss the side effect. So talk about side effect: weight gain, high blood pressure, mood changes, stomach ulcer, weakening on the bones. For that, we will be giving them. For that, I will be giving you medication for the stomach, to protect the stomach, proton pump inhibitor, omeprazole. Will be giving you medication to make the bone strong. Bisphosphonate. Will be giving you medication like aspirin to decrease the clots, because it can cause clots. Steroid can cause clots. Okay. That steroid will be giving for 2 years. For 2 years, we'll start with high dose and then we'll taper and decrease the dose. Okay. Always safety net. Whenever you have a patient with polymyalgia rheumatica, safety net for giant cell arthritis. So whenever you have a patient with polymyalgia rheumatica, safety net for giant cell arthritis. So if you have pain on chewing, pain in the eye, pain in combing, come right away. Okay. So all the time, because the management is steroid, 2 years steroid, long-term steroid, so all the time safety net about steroid. And with any case of rheumatoid, with any cause of rheumatology, we have 3 specialists. We have rheumatologists for further management, we have physiotherapists, we have occupational therapists. Please, any case of rheumatology, the management will be initial from you painkiller, and the advice. Further rheumatologist, further management. Physiotherapist to give you tricks on how to improve your condition and to give you like exercise to do to improve your condition. Occupational therapist, tricks on how to deal with your job. Okay, now I will come to osteoarthritis. Osteoarthritis is the opposite of rheumatoid arthritis. What do you mean, Dr. Mo? Rheumatoid, small joint, hand and feet. Okay, small joint, hand and feet. Osteo, big joint, weight bearing joint. So the location is different. Big joint, osteo. Small joint, rheumatoid. Number 2, rheumatoid arthritis, stiffness in the morning, and it is relieved by the end of the day. So work makes it better. That's rheumatoid. Osteoarthritis is the opposite. In the morning they are okay, and by the end of the day they have the stiffness. So it's mechanical. So due to movement, due to using the joint, the pain will start. What does that tell you? It tells you that osteoarthritis patient usually will be obese, high BMI. So don't forget the comparison. Small joint, hand and feet, large joint. Stiffness in the morning, lead by the end of the day. Stiffness in the end of the day, and in the morning the patient is fine. Okay, so you are an FY2 doctor, 50 years old. Natalie came with pain in her hips and knee, weight bearing joint, big joint. P1, pain in the hip and knee. I'm sorry about that. How are you managing? Tell me more. Psychosocial, how is it affecting your life? Daily activity. The first 2 questions, any trauma, any fever. Then gross, take 2, 3 differential, but trauma and fever are the most important and must. Then P2, P3 maftosa. And in this case, the patient will be obese, so DESA will be a risk factor. So the symptoms are pain and stiffness, which increased by the end of the day. It's not there in the morning, so it's worsened by the end of the day. Okay, in the big joint, hips and knees. Okay. Examination, vitals and joint. Management. It's all about painkiller. I will start with paracetamol. If it's not improving, NSAID. But the main treatment here is lifestyle. So this patient needs to lose weight, and exercise is one of the most important factors. So losing weight and exercise is one of the most important factors. So exercise, weight loss, because I said to you at first, osteoarthritis affects the weight bearing joint and it's mechanical. So patient will be obese. When they move, they will have the pain. So they need to lose weight, and you need to advise them about exercise. Okay? And painkiller, paracetamol and NSAIDs. Do they give them opioids? Yes, sometimes. Cocodamol if it's getting worse. All right? And the final option is steroid injection. Who's gonna do the steroid injection? Rheumatologist. Rheumatologist. That's why I said we will need rheumatologist in every case for further management. Steroid injection, rheumatologist. If it's not working, and don't forget that occupational therapist and physiotherapist. Physiotherapist will give you tricks, will give you what type of exercise you need. Occupational therapist on how to deal with your job if she is working. Okay? Alright, so don't forget rheumatologist for further management, occupational therapist and physiotherapist. Rheumatologist, occupational therapist, physiotherapist. Okay? And rheumatologist also for further injection, steroid or whatever. Okay? So don't forget main management here, painkiller and lifestyle. Main management. Okay? Okay. Come next to osteoporosis. Not osteoarthritis, it's osteoporosis. Osteoporosis is the bone weakness that comes later on, okay? Menopausal. You are an FY2 doctor, 62 years old. Janet had wrist fracture 3 months ago, which was managed. 3 months. DEXA scan was done 2 weeks ago, which showed osteoporosis. So the reason why they've done DEXA scan, because she had a fracture that already managed, but they've done DEXA scan to see if she has osteoporosis or not. Talk to her, address her concern, okay? So this case of DEXA scan showed osteoporosis. So it is diagnosed the case. DEXA scan showed osteoporosis. So is it a medicine kind of station or a counseling result kind of station? It is a test result. It says to you here, the patient had DEXA scan and DEXA scan showed osteoporosis. So I will start with, I can see from my note that you had fracture in your wrist 3 months ago. Yes, doctor. How did it go? How did it happen? Why? I need to know about the type of the fracture, because usually osteoporosis, they have fracture without massive trauma. How did it happen? How is it managed? How are you now? Then that's for the past wrist fracture for which they've done DEXA scan. Then I can see from what I had DEXA scan 2 weeks ago. Has anybody told you about it? No, doctor. Would you like me to speak about the DEXA scan result first, or should you have a chat, doctor? You can have a chat. So the chat, guys, is the history. What is the history? The history is simply the risk factors. The history is simply the risk factors. The risk factors. That's it. Because why, doctor, risk factor? Why don't we differentiate? Because it's diagnosed. It is osteoporosis. The question is it is diagnosed. So your job is to know the cause in order to manage the cause. Okay. So risk factors. Risk factors. That's the history that I will take. Okay. So the risk factors simply some medications like steroids. Some medications like steroids for high dose for long period. Steroids. Ask about medication. Some medical conditions like malabsorption problem, like some inflammatory bowel. So inflammatory bowel disease and malabsorption. Family history. Okay. Having eating disorder like anorexia or bulimia nervosa. All right. Not exercising. Okay. Smoking heavily. Yes. Some surgery like hysterectomy when they took the uterus and the ovaries. So the risk factors are scattered everywhere. Some of them in medication, in meftosa. Being on medication, long-term steroid is a factor. Some of them, family history of osteoporosis is a factor. Some of them is diet, is a factor. Some of them is lack of exercise, is a factor. Smoking is a factor. Okay? So scattered everywhere. The risk factor, which I only want you to ask about the risk factor because it is diagnosed the condition and you just need to know the cause. So you address it. If the cause is diet, you'll talk about diet. If the cause is lack of exercise, okay? Management. We know that osteoporosis weakening in the bone. That's the provisional diagnosis. Management, number 1. Senior, number 2. Investigations, like any other case, investigations. I don't know in osteoarthritis, have we mentioned the investigations or not? But on osteoarthritis, the previous case, investigations must be done. All bloods, as we know, all bloods, X-ray, as we know. So in this case, osteoporosis, number 1, I will talk to senior. Okay, number 2, I'll give medication like bisphosphonate. So bisphosphonate is one of the medication here that you must talk about in details. So senior, bisphosphonate. If you don't talk about bisphosphonate as a medication, you're not going to pass the station. So bisphosphonate, you will talk about it. It's tablets. It's taken once weekly. You will take it with plenty of water, standing or sitting, not lying down. Always you will need to be in upright position. Okay? It takes 6 to 12 months to work, and you might need to take it for 5 years or longer. Okay? That's medication. What else? Advice. Calcium and vitamin D supplement. Calcium and vitamin D supplement. Calcium and vitamin D supplement. So she will need to be on supplement. Calcium and vitamin D. Why? Because vitamin D will help the body to absorb calcium. So you must give them both together. Calcium and vitamin D. Then you will talk about diet. She needs to eat food rich in rich in vitamin D. So you need to talk about diet. Okay? So make sure you talk about diet. What food needs to be eaten. Make sure you advise her about exercise. Does she need to do exercise? Yes, she does need to do exercise because lack of exercise causes it. But some exercise, not the vigorous one, not the vigorous exercise because she's got weak bones. So you need to advise her about certain type of exercise. Okay, she needs to be careful from falling. She needs to eat healthy. So it's all about eating healthy. Okay, eating a balanced diet, doing exercise, and as I mentioned to you, avoid the heavy strength exercise. Okay, so certain exercise she needs to do. All right, guys, that's some recap of what's happening. Okay, and final case is septic arthritis. It has not come yet in the exam, septic arthritis, but I will discuss about septic arthritis quickly. Okay, always you need to safety net for septic and always need to exclude septic. It has not come yet, but the patient will come with pain in the joint. For example, pain in the knee. Pain in the knee. So, how can I help you? Doctor, I have pain in the knee. Explore, tell me more. The pain will be acute. The pain will be acute. Okay, anything else? Fever. So, severe pain and fever. Severe pain in the joint and fever. Okay, the patient will be drowsy, not himself. Then any pain anywhere else in the joint? No. Examine all the other joints. Go for gross. Everything is negative apart from severe pain. And the patient is septic, which means he's confused, lethargic, not himself. Okay? And fever. P2, P3 maftosa, not in details because it's an acute condition. When you examine the joint, when you verbalize, observation and knee examination. When you examine the knee, it will be hot, tender, swollen, so septic knee. When you manage, don't forget it's an infection in your knee that might have spread to your body as well. So when you manage, make sure you need to, number 1, admit, number 2, senior, number 3, investigation. What are the investigation? They do ultrasound, they do bloods, in the blood, full blood count, blood sugar. Okay, they take sample from this fluid sample and they send the sample aspiration. Okay, and this patient will need to be on fluids, will need to be on antibiotics, painkiller, and it will go for wash, joint wash. So joint wash is cleaning this joint. So joint wash, you will need a procedure, joint wash. Okay, but after stabilizing the patient, and you know that because the patient is septic, take 3, give 3. So you will need blood culture, urine output, and you will give 3 oxygen, fluid, antibiotic. And further procedure by the orthopedic or the rheumatologist is joint wash. All right, it is an emergency. Septic knee, it is an emergency. It is an emergency, and the patient cannot wet bear. Okay, sometimes we give it WIFE. WIFE, what do you mean WIFE? W-I-F-E. W for wet bear. He cannot wet bear, and white blood cells will be high. I, inflamed joint. F is the full blood count. You'll find ESR high and white blood cells high. E, ESR is more than 40. So WIFE, W-I-F-E. W for wet bear. The patient cannot wet bear. W for white blood cells high. I, inflamed joint. F, fever. E, erythrocyte or ESR is high. ESR is high, more than 40. Okay, guys, thank you very much. Thank you very much.